rapid transformations that are happening in health systems across the country, born out of necessity due to the COVID-19 pandemic, represent an opportunity for us to fix some of the structural deficiencies of primary care that existed before the pandemic began. We propose in this article a way to integrate telemedicine, patient-generated data, pre-visit planning, and population health into an enhanced primary care intake and care optimization process that would be delivered by humans and augmentable with artificial intelligence. Take telemedicine, for example. Before the pandemic, few organizations were doing telemedicine at scale. At Stanford, for example, we were doing about 300 telehealth visits per day. This jumped to about 3,000 telehealth visits a day during the height of the pandemic. And in fact, the vast majority of our visits today are delivered through telehealth and video visits. My name is Stephen Lin. I'm the Chief of Family Medicine and Clinical Associate Professor in the Department of Medicine at Stanford University. The name of this article is Retooling Primary Care in the COVID-19 Era. Speaking to my colleagues across the country, similar things are happening in terms of telehealth as a dominant form of care delivery. And so we feel like this represents a paradigm shift for telemedicine and should be an essential part of how primary care is delivered, potentially increasing access to primary care, especially for vulnerable populations that have trouble accessing the care system right now. This telemedicine mode of delivery should be enhanced with appropriate technology tools that allow us to contextualize the patient's symptoms and health status so that we can better care for them and determine whether or not they actually need a visit or if telemedicine is an appropriate mode of care delivery. Current state is that it's very difficult for us to figure out which patients should be seen in clinic versus which patients can be managed appropriately via telehealth. There are tools that are being developed now that can leverage the power of machine learning and artificial intelligence to help us risk stratify patients to determine which ones are appropriate for in-person visits and which ones are appropriate for remote care delivery. And these tools can also help us triage the patient in a way and contextualize these symptoms so that we can better prepare for the visit, so that visits are more efficient and also higher quality, delivering the type of care that the patients need at the time that they need it. In terms of prevention will be ignored if not done between visits. We know that 99.9% of the patient's life is spent at home, not in our offices. And so I believe that there's an opportunity for us to use technology to really proactively manage and reach out to patients intra-visit to help them close their care gaps, to meet their lifestyle intervention goals, to make sure that they are adhering to treatment regimens, and to motivate and include the patients and empower them as an important member of the care team. One of the important things that I think we need to focus on as we move our care into the virtual space is that there will be a segment of the population that will be left out, the digital divide. And so what we're seeing in our institution is that patient populations that are less technology literate, or they don't have access to the appropriate equipment, if they're homeless, if they're lower income, if they're in very rural settings where there's not a reliable wireless connection, for example, for a video visit, that they are left out of this type of care. And so I think it's incumbent upon us as we shift and develop these new modes of care delivery to think about these patients to make sure that they're not left behind. And I think that means a couple of different things. That means making sure that our technology is affordable and accessible. That means that there are payers that recognize the health equity issues involved to make sure that all of the population, all of our communities are able to access care in this way. And it also means expanding coverage for these types of services beyond what we're able to do right now to make sure that those who are underinsured or uninsured also have the ability to get adequate care, especially in times of crisis like the pandemic. Thank you for listening, and thank you for reading our article.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.